طيب.
Hello and welcome to our lab. My name is Anastasia. I am the author of the Non-Scary Book and the editor of the volume on humanity and
Блин,
empathy
что переводчица не переводит?
in healthcare. I think we have some translation issues, but maybe I will just keep going. Hopefully that it will get fixed. Um, yeah, and we have decided to do this series of talks and discussions to learn about the best practices of teaching communication and integrating it into university curriculum. We have had a series of discussions with the Ukrainian professors who have already started teaching these courses as electives or integrating it into the curriculum of their own courses. And we are also launching a series of events with international speakers. So the first one was with Jane from Denmark, and she talked about the challenges of teaching communication. And today we will be speaking with Orit Karnieli-Miller from Israel about the best practices of teaching communication. And we are doing all of this also to help you learn about the guide that we have developed that is called Humanity and Empathy in Healthcare, a guide for teachers. We have developed it together with 15 Ukrainian practitioners to help medical educators learn more about empathy and communication in the medical setting. And we are also doing this to learn about the lessons learned from the international experience. And that's why we also invited Orit to speak today. I just thought that maybe I could speak a little bit about you, Orit, and then give the floor to you just to introduce you. I should say that Orit has kindly agreed to do this on a very short notice. So I'm very grateful for that. And Orit is teaching and takes a leadership position at the Gray Faculty of Medical and Health Sciences at the Tel Aviv University. She is also the head of the Department of Medical Education at the Sackler Faculty of Medicine, the director of the Communication Skills Training, and she was also the member of the board of directors at the Academy of Communication in Healthcare. And the deputy national representative for the International Association of Healthcare that helped us meet. So Orit is a very experienced professor of medical communication and also researcher. And I have asked her to speak about her experience of teaching it, developing the curriculum, and working with the topic in the medical education setting for us today. So, Orit, maybe the floor is yours, and maybe I should just remind our viewers that we will be that they can leave their questions or comments under the air, under the video or the post, and yeah, we can move forward with your presentation, and then do the questions a bit later,
Great.
please.
So I trust you with the questions, and thank you for the introduction, and thank you for all you have been doing to move this forward. I was actually very excited about what you're doing and the opportunity to join. So you asked me why I joined, and this is actually the main reason I joined. The minute I heard that it's for Crane, I said, of course, I'll be there. My heart is with you in the past few years since the war started in Ukraine, thinking a lot, protesting when I can, and definitely relating to the experience since October 7 and with what's happening around here in Israel, which is tough as well. And it was interesting that when my very good friend Marcy Rosenbaum asked me, "Can you do this?" And it was like a week ago, about a week ago, a week and a half ago. And I said, and it's for Ukraine, I said immediately yes, even though it's really not the good timing for me, but I said, yes, I will. And the first question I asked myself is, how can they be available to think about teaching communication skills and, developing where they're in the middle of the war? And then I was like, oh, that's what I'm doing. I'm in the middle of a war and I am teaching my students communication skills and I am improving those things alongside these difficult days. And I would say that even when I asked myself these questions a year and a half ago and throughout this war, I feel like communication in healthcare is critical, even definitely even during wartime. So we have to have health professionals and they have to know how to break bad news and they have to know how to communicate empathically and they have to learn how to deal with their stress and not outleash it on others. So I feel like we as a group have an obligation to improve healthcare, which is critical in regular times, but definitely in war times. So that's a little bit about that.
Thank you, Orit.
So the last thing I'll say is that my heart is with you. It's also with our hostages and what's happening. Hopefully in both places, I can't say peace, but some treaty will come. So I'm moving forward to actually the topic of discussion or what we were meant to talk about. And I wish we would communicate with each other, but I'll do it like this. That's it. I'm talking to myself. I'm talking my head off. So when you think of it, of a health professional, of a physician, for example, I teach medical students and faculty. So what is the most commonly performed procedure that is done by any physician? And obviously, my answer would be now the medical interview. The medical interview is done many, many, many times by physicians. It's actually, if we ask ourselves, how many interviews does a physician conduct over his lifetime? You can try thinking what you expect or what you think, but I would tell you that it shows that over 200 interviews. Yes, they look differently. A medical interview in the ER looks a little bit different than the medical interview in the family physician place. A medical interview when it's walking or versus with a child, it looks a little bit differently and it has different implications. But they all have the same core principles and they all require the same core skills and attitude that we actually teach. In the past, there was minimal training. So people assume that you learn it from being and observing others and what they're doing. There was limited teaching and focus on this issue. Today, we have a lot more, but it's still limited and we don't have enough feedback in real-time practice, especially when we compare this to other procedures. And that's what we're actually trying to change because many of the day-to-day experiences relates to communication skills, and I'll talk about it a little bit more. And it doesn't make sense that there's not enough teaching because today there's so many challenges. The knowledge or the information that is now in the hands of the patient as well, that it's not easy to deal with. The time pressure that is terrible in medical interactions, patient expectations of more shared decision making and more dialogue, and the electronic medical records that take time and efforts from people. So what I will talk about today is a little bit about the importance of teaching communication skills, especially why do we need to teach them? Why do we need to spend time on talking about and practicing this skill? And how and when to teach this. But before I run into this, I would like to do small disclosures that I think we should know. The first is I saw that in the questionnaire, many of you actually practice this. You're either teachers or definitely health professionals, and some of you are only teachers, some are health professionals. And I know that you know, and many of you practice this on a daily basis. But what I'll do today is try to organize things a little bit differently because to know how to do something is different than to know how to teach it. It's a different way of looking at things. And what we'll try to do today is just putting common ground and some shared concepts and some shared ideas that I would love to hear comments on. I must say that I will focus today only on patient-physician slash professional communication and not about other forms of communication that are really important um, with our colleagues, with our teams, with our bosses. So they are part of teaching communication skills. It's just that I will not focus enough about this today. And I'm not focused on what we teach, but rather more why and how we teach those things. And I wish we had a dialogue now, but I'll deal with the fact that I'm talking my head off. So I'm doing this as a part of a wonderful organization named EACH, which is the International Association of Communication in Healthcare, that really tries to get heads together from different countries and move communication in healthcare forward. And I am doing this with a help or with the niche from my great friend, Professor Marcy Rosenbaum. So we all communicate every day. That's what my students sometimes say. Well, we all communicate every day. I've been communicating for all my life, they say. So why is it so special, the medical interview, and why do you need to teach us? Okay, they even enroll to medical school communicating with someone. And this is where I'll give you some information that you know, but I like to do it organized, and this is also what I do with my students. So the medical interview is and has unique characteristics. It's a challenging task. You have to foster care, communication, and competence. You have to create a sense of confidence. Think how hard it is for a medical student to create a sense of confidence. You have to establish trust, sometimes in a few seconds, and you have to maintain it over time when you ask questions, when you share information, when you deal with things. You have to deal in the same medical interview between integrating clinical reasoning and thinking, what's the diagnosis and what am I missing and what am I forgetting, with person-centered thinking of looking at the other patient, the patient, and thinking, what do they need right now? Why did I scare them? Are they telling me everything? What should I ask them next? You need to collect extensive personal and very times intimate information, and students have challenges with this, asking about drugs and sexual behavior, and asking about their day-to-day experiences and embarrassing questions that usually will not be discussed on their first date with a person. They have to perform physical examinations, sometimes on sensitive issues, and it relates to communication because how do I talk with you about touching you? How do I say that what I'm going to do right now will hurt you in order to help you? And that's part of communication during physical examination. The medical interview requires various skills. So I need to learn how to ask clear and direct questions, when to ask open-ended questions, when to ask closed-ended questions, because it's not that there's one best way, but there's one best way for each and every type of situation. I have to understand and interpret the information collected and sort of to think what's going on here from a medical point of view in a diagnosis. And I have to do this while I'm talking with someone, which is not easy. I have to deliver information. I have to involve patients in decision making. I have to tailor this information and involvement to the patient in front of me, which is a big and challenging task. How do I know who wants to be involved and in what way and what would scare them too much? And how do I deal with a family and not only with one patient that come into the medical encounter? And I have to ensure understanding, to enhance motivation, to help them get ready to actually adhere to the treatment that we've decided together on. And all of this, if it wasn't enough, what I've said right now, must be done when I have patients that I really don't relate to their behaviors or that I find them pretty problematic or sometimes they contradict the medical advice given, or I need to try to influence and make change, but I need to do this in a non-judgmental manner. I need to engage with diverse populations, okay? To deal with people from a different culture, from a different background, from a different gender, from a different personality type, and to do this in a way that builds trust, in a big way that is respectful. And I need to convey complex medical information in simple and clear language. And this is very interesting because what we see with students is that they start and they speak simple, but then they learn more science of medicine, and then they start talking in the jargon and in words that are more professional. And then we have to help them go down and speak in a simple language and to tailor it to the person in front of them. And we have to address their emotional responses of patients. So people come with emotions. That's what I tell my students. For your empathy issue, which is a huge thing. Some students would say, why do I need to know be empathic? That's not something that's really critical. And I say, you treat patients, you treat a person. A person comes with emotions. Illness comes with a bag of emotions. So that's what we start teaching them of how to deal with this emotional illness and vulnerability. And like I said before, it's within a very limited time. So if I had all the time in the world, that's fine. But usually people don't have all the time in the world, and that's part of the issue here. So I hope I've convinced you that it is challenging. It's really not easy to hold all these communication tasks all together. And no one is actually born with all of these skills. So everyone enters the profession with some natural strengths. Someone could be great in interpersonal relationships, but then he needs to be very focused and ask very close-ended questions. Or someone could be great in remembering the questions that they need to ask and being very technical, but then they don't recognize emotions and they don't know how to deal with them. And this is very challenging, and you have to combine the content that is discussed with a context, with a patient type. And that's why we need to practice this. That's why we need to learn this. I bet that people from your experience, when you taught communication skills, every time I teach it on a didactic, on a theory, everyone says, oh yeah, sure, of course, yeah, what, doable. But then when you get to do it, difficulties arise. That's where the challenges come. And that's why we do this. Anastasia, I see you want to ask a question.
Yeah, I mean, I think we often come across this attitude kind of like, I've been doing this for 20 years, so what can you teach me? But I think that doing it for 20 years doesn't mean doing it well for 20 years. And that's like there's a major difference there.
I completely agree with you. So doing it without really learning and reflecting on it and finding the right way to do it is a huge thing. And what we sometimes do is we say, oh, yeah, I'm here not to teach you. I'm here to teach the students through you. So I will teach you how to teach. And by the way, I hope that they'll learn how to communicate. So that's the trick we do. Don't tell it to others. But that's the trick we do. And with the hopes that they will actually earn those skills. We always see, and this is about habits. And by the way, I'll do the hands because if I have time, I'll do a trick with the hands. This is about habits. People have habits. The habits don't necessarily mean that they have good habits, but they have habits. And we sometimes need to change the habits later on. So due to the critical importance of effective communication and optimal management of the medical interview, this has been a really big interest of research and a really big interest of different organizations. EACH that I've mentioned, and ACH, which sits more in the United States, and .com and Academy of Professionalism. And there are millions of papers now on these topics. And this actually indicates the need for this. And I can tell you that I'm studying communication in healthcare for more than 20 years. And when I say my focus is on breaking bad news, there isn't isn't any time that anyone stops me and says, "Oh, I have to tell you about my experience with healthcare." And I hear shocking stories. So at the beginning, it was shocking stories, and I said, "Oh, I'm gonna change this. Yeah, that's my mission." Today, I hear them, and I said, "Oh no, we haven't managed to change it yet." But we're on our way, and hopefully we will.
But maybe the whole idea about teaching and learning communication is not about destination, but about the path. Because there is always space to learn and to grow. And I think as long as we don't feel too disempowered by the fact that we may never be perfect, we can still do a good job on the way.
Definitely. And I tell you that I'm growing every time. Okay, I'm growing in my communication skills with dealing with different people. I'm growing in my teaching skills and dealing with different practices. I've just finished a conversation an hour ago working with head of psychiatry departments, and we were growing together. So that's part of it. I think I completely agree with you, and that mindset is for me the best one to deal with. So if I'm talking about evidence, there really extensive evidence shows that effective communication skills is really important. It is associated with, for patients, better outcomes, improved diabetes control, better pain management, higher medication adherence, greater satisfaction with their care, which is very important for them to come back and to do whatever they need. It is very relevant for healthcare providers. So it's helpful for the healthcare provider itself. It increased the sense of meaning and commitment. It relates to higher job satisfaction, to decreased burnout, which is a huge issue in healthcare, to reduce workload related stress, and actually by 70% fewer malpractice claims. By the way, that's why hospitals invest in communication in healthcare, and that's why insurance, medical insurance, says if you don't have good communication skills, I'm not going to renew your insurance. Go do that skill. That's what happens in the United States. Yeah. So that's what they do. They say, okay, at the one point they say, because they saw that it relates to that kind of issue. And it's also very helpful for organizations. So it improves performance on external evaluations. And it creates a more positive workplace. So if we have good communication in our team, then we'll make less mistakes. We'll feel more comfortable to talk about difficulties and challenges. And it does impact greater overall staff and satisfaction. And this is critical to deal with it. And by the way, this is why, at the end of the day, when we look at America and Canada, they said the core competencies of a medical professional, a medical student, a medical graduate should include communication. Okay. And if you see these lines, this is the ACGME, which is related to medical education. The only one that has 6 lines related to other characteristics that are needed by the medical school is communication, interpersonal skills and communication. The CAN-MEDS has communication, but of course, to be a collaborator, you need good communication skills. To be a health advocate, you need to know how to explain things. So actually, communication skills is core to being a good physician. And that's why it's very clearly in the accreditation processes and in general teaching of this. So it's nice to say that we need it, but now your question is, how do we actually teach, how to teach it in best practices? So I would ask, and you can't answer me, but answer in your heart, how do you teach procedure, skill, suturing, blood drawing? Okay, how do we teach any procedure? So of course, any procedure or any behavior is learned best by investing time in the teaching, by doing gradual learning, not at one point I'll do a whole session or a surgical procedure. It's with repeated opportunities with guided practice. You see one, you're guided within it, you get feedback on it, you reflect on what you did well, you reflect on what needs to improve, you get another feedback, you get assessed, and this is what we're going to see, and this is what we're going to talk about today. So, by the way, I put barcodes of some of my papers. Every time it's a different barcode, and if you want anesthesia, I can send you the papers later on or the links to them. But this is, for example, from a paper that is a position paper for EACH about how to teach breaking bad news, but the rules, I've put them on best practices in general. So when we think of effective teaching of communication skills, the first thing is that we need to teach it continuously. It has to be taught throughout the years from day one. It's part of becoming a physician. It's part of developing into that role. And we do this with all of the things that even in your questionnaire you said you use. So we include theoretical foundations. We talk about the human nature. We talk about patients' tendencies and why they would do things. We talk about denial and its importance. We talk about emotions. We talk about physicians' biases to let people understand their way of thinking when they meet people or when they do. We talk about first impression. So we talk about the theoretical foundations. We do teach a structured communication skills model. So every school chooses its own model. And there are various models that were invented around the world. So, for example, the Smith model in ACH that talks about patient-centered interviewing, the Four Habits model by Frankel and Corrupt that talk about 4 stages of the interview that is helpful. Jane spoke about the Calgary-Cambridge model that is very helpful, and the EACH focuses on that model. And we use, it's funny you said that word, but we use the PATH model, medical interview, that we have actually combined from the different models, but works best for our culture that has 4 parts. Again, I won't go into it. I'm just saying that we need to choose a model. The model helps us organize the conversation. The model helps us learn the skill into the ability later on to improvise when needed. Other recommendations include the need to practice. There's no way to learn a procedure only theoretically. So you have to practice this, and you can do this via role plays where one of the students can be a patient and the other student can be a physician or a student, a medical student, and they interact. You can do it through simulations, which are very, very helpful when you have a simulated patient, which is an actor, and I give them a very long description of their symptoms and their concerns and their thoughts, and they actually, the medical student does their interaction with a simulated patient, it's videotaped, and then they discuss it, and then they can see the video. And recently, I've also developed an AI chatbot, specifically about breaking bad news. And I can tell you, you can also use this to teach. It's not instead of the other processes, it's in addition, but maybe I'm too conservative when I'm still saying that. So you can actually even use AI. But what's important is not only the practice. The practice is good, just like you said about the physicians. Practice is nice, but it's not enough at all. So what has to come after our practice is a process of reflection, of saying, what happened here? What went well? What didn't go well? Why? Okay, what happened to me? What happened to the patient? And then receiving feedback. And the feedback is from the simulated patient. And feedback is for my small group peers who actually share their thoughts of what they've noticed, what they liked or felt worked well, and what I can think of improving or do differently, and feedback from an experienced facilitator. So most of our studies are in small groups. It depends on 6 or 8. They saw that there was a question about it. It depends on 6 or 8, actually depending on the money and depending on the number of hours that you have. But it's a small group that can actually do this process, which is very important, and can even have an opportunity to retake. So if I finished it and I didn't do something well, I can have the opportunity to look at the simulated patient again and say, can I share with you the news in a different manner to see that I know how to do this? So this is part of that process. But what we also need to focus on is the medical student as a human being. So how hard it is to actually break bad news. It's devastating. How difficult it is to sit in front of a patient who has no money, who lost someone in the war, who lost their job. And all the time, the medical student has his own stress. So part of what we're looking at is really looking at the student as a person while teaching communication skills and acting in the same empathic manner with them and involving them in that kind of way and trying to work with them on resilience. So for example, I would say to the medical student who was like she couldn't she came to do the simulation. She said, "Okay, I'll be first." And she didn't find herself and she did it and it didn't work well. And I first asked, "What happened to you?" And she said, "I prepared my pages, so I'll ask the questions, but because I jumped into the simulation, I didn't find them and I was so confused." And I talked about your comfort is very important. Take the other minute, find your papers. If you are comfortable in your chair, you can actually be more available to the patient. So we talk about resilience in different ways. Yes.
So basically, what I hear you saying is that if you, as a teacher, treat students as human beings in those interactions, this increases the chance that they, as medical professionals in their future career, will treat their patients as human beings, not just as objects of treatment.
Definitely. Definitely. We have to do that. And I even sometimes very clearly state it. For example, when I give feedback to a student and the student didn't do a good summary of the medical interview. So when I almost finished with my feedback, I asked them, "So let me know, please share with me what you have taken out of this conversation." And then he says what he's taken from the feedback. And then I said, "That's great." And I answered this. And then I said, "What I've done right now is exactly what you can do with your patient as well, because it's an important thing." And then it relies on them. Or if a student says, "No empathy, I don't need it," and I answer this in an empathic manner of curiosity, what happened to you with empathy? Or what happened to you? Why are you concerned about this? Why did you decide not to deal with this emotion? And they share a story of not knowing how to deal with emotions and being so overwhelmed. I actually use the same model that I teach on empathy with them and give them that model so they can use later on. And then showing why empathy can help them as well as help their patients. And this is part of it. So it's about doing it, but also about explaining that I did this, because otherwise they feel it's magic, what I've done. So I work on both processes. I'm with you, but then I'll look at it from a different level. And I'll say, "Oh, look, this is the skill I used. Was it helpful for you?" "Yes." "Oh, great. Then you can try using it with your patient."
I just thought it's really beautiful how you talked about magic, but if you think how much magicians train their tricks to show them. So
Exactly. Exactly. And I think that's the issue. We need to train here. We need to work on this. I completely agree with you. Even for me, the empathy took me a while to relate to how to do this in the manner that I think is the best. And of course, I tell them I fail in it as well. Okay, but then I reflect. I use the same process. I reflect. I try to figure out why it happened to me to improve in the next time. So I'm the one who actually got most of what I'm teaching. I use it on my daily basis.
It's no joke that they say if you want to learn something really well, start teaching it.
Exactly. Exactly, exactly, exactly. So if we think of how to teach it, we have to enable real life observations because what's happening, I call it the tsunami. If I only teach this at the preclinical years and I teach it, then I teach them what I think is needed to be done. And sometimes they say, you teach the ideal. I say, I do the desirable, not ideal, but never mind. And then they go to the clinics, and what they actually see is, oh my God, not good. This is not good.
It's like
So
not ideal, huh?
not ideal, not desirable, very problematic. They would actually say it's problematic, but they would say, then we can't do it. We're not going to do it. We're not going to teach because they see those physicians most days. They don't see me as a communication specialist many hours. Okay. So I have to deal with this tsunami. I have to say, go out, observe physicians, come back, look at that observation, see what worked there, what didn't work. Later on, when I teach a model, see what worked there, what didn't work, and was the model implemented? And if not, how would you implement it? So it's doing work with those real life observations, not ignoring them, asking them to reinforce what they've learned and to train their mind to think of what they could have done differently. Otherwise, we're losing them.
But it's really interesting that you emphasize this because I think it's also like our colleagues in Ukraine often talk about how they teach these wonderful ways of communicating, and then the contrast is so huge between what they teach and what the students see in the hospitals. And that's always the challenge, like what to do with it. And what I'm hearing is that the solution is not to judge whoever is not following the model, but actually to turn it around and use it for your own self-reflection and learning, so that the learner can actually just build up on this and use it as just one of more brick to the learning, not just a point of dissatisfaction or disappointment.
Exactly. Exactly. Because only if it's a, oh, so I learned not to do, we don't learn it. If we don't do a good reflection on this and we don't find an alternative, then we don't learn it. And this is a huge part. You can see, I have a different paper, I'll send it to you, in 2018 in medical education, talking about how to use it in Breaking Bad News, for example. And it's critical. It's critical to actually deal with it because this is our biggest enemy in communication skills training. And of course, to assess performance. So it's not only about doing the formative assessment that is really the main thing and being very empathic and reflective and dealing with things. At the end of, now we do it at the end of each year, but at the end of each year, at the end of each course, we need to assess it. And we need to give a grade. It's difficult. We're very empathic. How can we give a grade? And what I tell myself on that minute is that during all year long or during the entire years, I'm very focused on the student. When I look at the exam before they go meet patients, I'm focused on the patient. Is this responsible to send a student to that patient or this student to patients? So that helps me. And in any case, even if he fails, I said that's a good thing for them. We work together. I work with them. I give them feedback individually. I work on their barriers and challenges. And then usually they make a leap and they can go through it. If not, then it's my responsibility for patients. It's fine. They'll need to learn it or leave the practice. So we do this basically because smarter people than I, Confucius, said, I hear, I forget. I see, I remember. But I do, I understand. And this is part of the practice. And what I added is what we talked about now. I reflect, I improve. So if people only say practice, 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 experience will teach me, I said no. Experience with reflection, with feedback, with a process, then I will improve. And this is part of this deal. So when we think of developing those interpersonal communication skills, we talk about spiral learning. So it's something that I said it happens from day one, but it should happen every year and every time with different chances and different things to do. So we do have theoretical didactic teaching, and I can teach the basic of the model and the basic things related to communication at the beginning. And later on, when they grow up, I will talk about trauma-informed care. And later on, I'll talk about domestic violence. And later on, I'll talk about something else. Then they need to practice evidence-based communication skills in the different methodologies that we've talked about. Practicing is very important. And then they need to reflect what works and what doesn't. Sometimes, or every time we do it verbally, but sometimes they do it in writing. Sometimes they look at their video and write it down. Sometimes they look at someone else, but do a guided reflection with feedback about this. They receive and give feedback. So our students in the small group practice giving feedback, which is very important. I tell them you have to write your feedback to your friend. You have to know how to give feedback. It's part of your role later on as a physician. And giving feedback to other requires you to observe their simulation or to observe their practice and learn something for yourself. What will you take from what they've done? And they actually don't do it today anymore by themselves. So I would watch you, Anesthesia, do your simulation, and then we'll watch Tanya, and then you guys will watch me. So at that point, when I do it, I already adopted something from you, and I already learned something that I wouldn't do from someone else. So we use that part of teaching. And integrating the feedback, really, really with an opportunity to rehearse. So sometimes when students would say, oh, I wouldn't know how to set this boundary to the patient. We're working on boundaries. Then I would say, okay, try this. And they would say a sentence. And then the patient would say, didn't work for me. I would add, da, da, da. And then someone else tries it, and then they try it again. But if we do some rehearsals or restart, it's really helpful because it's not only about what I don't know how to do, but I start working with a language and now I know how to do this. And really applying it in real life settings. So they start with observing the clinics and again reflecting on what's different and what's close. But then they start on doing part of the interview with a patient, and then they do another part of the interview, and they come back and we talk about it in our small groups. And it's sort of a process that they will go through. And of course, it begins every time with the same cycle on a different topic, on a different issue. So how and when and how do you do it? So we look at this, and this is Marcy's word, as a curriculum rather than a course. So communication skills, especially because it's a competency and it's not only one course, for us, it's from day one of medical school till the 6th year. At the end of the 6th year, they have the Breaking Bad News course. They learn it throughout the years, and it's a process of putting more and more steps and more difficulties. We started early, okay, to share and to emphasize it's central to effective communication. When I did my doctoral dissertation, I remember a physician who did bad news very terrible. Really, she did a terrible job. And I was pretty shocked every time I was watching her. And when we went out, I said, what's going on? And she said, it's terrible. I need a coffee. When I took this specialty of gastro, um, I thought I'm going to do procedures, I'm going to do things, but 95% of my work is talking, is communicating. I hate it. And you could see she hates it. You could see the damage that that makes. And that's really not a fit. That's really unfair. So part of it is saying, yes, you're going to a profession that relies on, of course, different specialties have different percentages in their work, but every specialty needs communication skills. It should be integrated with other clinical skills and knowledge. So clinical reasoning. So when we teach communication skills, and it's always funny because they say, I'm the one who insists on teaching it with clinical reasoning while I'm the non-physician. Okay, I'm a PhD in social work with communication skills as my specialty and medical education. But I'm insisting on integrating the two because otherwise I know what will happen. When they start thinking clinical reasoning, they'll just say goodbye to their communication skills. And what they need to learn is to learn it together. When they need to learn communication skills when they're doing physical examination, focusing on what's happening to them when they do it and how to deal with it later on and stuff like that. And it's a helical. So it's a continuous building of skills as they advance through learning. For example, we teach it from basic communication skills. So we teach the PAT model. We start only with the opening at the beginning. They practice this in role plays. Then we do the opening and gathering information or the assessment, and they practice it with simulated patients. Later on, we add some complexity of a psycho or social issue, et cetera, et cetera, et cetera. When they're in the clinical years, we add advanced communication skills. So we had a patient with an asthma, but she's actually domestic violence. We have a cultural competency issue with a religious person who doesn't want women to care for them or has different beliefs that are playing a role or their own biases, the physician that may not find the solution. We look about boundaries and sexual harassment, and we teach assertiveness, but in the good way that we actually teach it. Assertiveness that is respectful for the needs, values, and rights of oneself and the other. And then we move toward teaching breaking bad news, dealing with medical errors. So it's building and moving forward with the different skills from basic to advanced. And it is a lifelong learning. So we need to teach it in postgraduate and working physicians. I always tell my students when they start judging physicians, I say, I have to tell you a secret. They haven't learned it. They are not, they didn't get what you get. And the students are like, really? No chance of, not learning? And I said, yes, please be empathic. They didn't learn it. They learned by whatever happened. Some of them had wonderful role models that taught them to do it really well, but some of them were unlucky. So we practice on that. And we need to do it as a continuing education for professionals, okay? To hone, to advance skills. So of course, the challenges that senior physicians have are different. So I talked with you about assertiveness. They need to deal with assertiveness when the junior is very different or very acting in a bad manner toward them. And they need to now answer it, but in a respectful way, in an assertive way. And we need to prepare our role models and teachers. So, for example, what we added in the last 3 years, I just finished my role as the head of the department. Hadass has changed me, has replaced me, and I'm on a sabbatical. But what we have added in the last 3 or 4 years is have the clinical supervisor from internal medicine come to a whole day with us, and we actually do with them simulations of what the students will encounter and how they should give feedback on communication skills. So that's part of what we're actually doing. So I'm really at the last minutes, just before the important questions that I know are waiting. But I would ask you, everyone, to just think for yourself, what is your take-home message from the whole very long conversation that we have, or the conversation, sorry, lecture that I have been doing, talking your head off. What is your take-home message? You can write it down, Steve. Yeah. Do it. I would say a little bit to summarize is what I was trying to say is that it's very challenging. It's not an easy task, not to teach it, but also not to do it. And that is why we need to actually teach communication skills. And it's not only about being nice, or it's not at all about being nice. It's critical for patients. It's critical for physicians and healthcare providers' well-being. It's critical for the organizations. And like any procedure, it actually needs to be taught and practiced. And we can use a model, whatever model works for you, but to teach it cognitively and to explain it and to practice it and to allow reflection and to care for students and to assess them. Because we know that what we don't assess, students know is not important. So that's why we need to assess those skills at the end of the day. And it needs to be a spiral way of teaching that comes back to it in different times on the curriculum and in different ways. And to do this in a gradual manner so it won't look too hard and it would be paced in their needs and integrated with other skills that they have to learn. And don't neglect faculty. It's for them to be using best practices so they won't be judged in a bad manner and that they can teach it really well and not just in that way. Last thing I'll do before we go is I invite you to do like this for a second. Hey, Anastasia, open your mic so I can ask you a question.
Yes, madam.
Okay, so open it like this. Now close your hands just like this. Great. How does it feel?
Good.
Oh, right? Great. So now open it and then just turn it around a little bit. Close it. How does it feel?
Unusual.
Unusual. Yeah. Sometimes for me, it hurts here, right? Something. Now go back. How does it feel?
Like home.
Oh, exactly. Once again.
Well, that feels like an entry to a home, but not home yet.
A little bit better. I wouldn't stay there, but a little bit better.
Yeah.
The only difference is its habits.
Ah.
It's our habits. There's no real difference. It's our habit. So when we start teaching communication skills, we're changing some of our habits. And it doesn't feel comfortable at the first minutes. But
Mhm.
what I love to see in our students, and when it happens, it's like magic, is that suddenly the habit, the best practices. And when that happens, then it's wonderful. So it requires some patience and it requires some things, but it gets there. So of course I have to say thank you to my colleagues who are working with me on specifically this presentation, or in general, I have wonderful colleagues. Some of them are not mentioned here. And I wanted to thank the grant that helped us with the assertiveness, actually, research. And I'm open for questions.
Thank you so much, Orit. What an inspiring and really simple exercise to feel the difference. So I just want to take the opportunity to remind our viewers to write their questions or type their questions under the video so that we can ask you. But we also have a collection of questions from the registration form, but I'm going to start with my own, if that's all right. I think I was very touched by 2 points of yours. One, you talked about how the relationship to a student and should be very similar to what we expect from them in relationship to a patient on the one hand. And then one of your last points was about like treat the faculty well. And I would really like you to speak a bit more about maybe the organizational culture in your university in terms of like what are the main principles that you use to build these relationships between and how the relationship to the faculty, like between the management and the faculty, reflects to the relationship of faculty to students and then students to patients. Like maybe you could speak a little bit about if there is interconnectedness or something that is done on purpose to make it work. That would be very interesting.
Oh, thank you. So I would say that my department, which is the medical education department, um, really takes seriously the fact that we need to look at our students as human beings and treat them very well with empathy and caring. And this is part um, of what we do. So we have small groups that go throughout the years focused on them and their professional development and their personal experiences and reflective journals about what they experience and what they do when we try to prepare them. And in every encounter or every time we teach communication skills, my message for the faculty is always um, it's not about saying everything in the feedback. It's about building the relationship and about trying to send the message forward or raising the issues, but doing it in a manner that respects the student and is empathic to their challenges. And it's hard because some students are challenging at some points. And when you teach communication skills, many are like, don't are showing resistance and saying it's not important and things that are for ourselves. So we're working on that. What you were referring to before is when I teach the students and their faculty about the hidden curriculum. So there's what we teach is the formal curriculum. You know, we have the syllabi, we have the books, we need to be empathic, we need to be da da da. But actually, the hidden curriculum is the most impactful thing. It's what students actually see in practice. It's the way we treat them. If we don't answer the questions or we don't explain why we do things, then why would we expect them to do that with their patients? So part of it is teaching them in the way that we want them to act. Um, and we have done an intervention in surgery department, division. And everyone told us when we were thinking about the intervention for professionalism communication skills, skip the seniors. There's no chance. Leave them, just do juniors, teach them communication skills. And we said, no, it's unfair. By the way, it's inefficient because they look at the seniors, but it's unfair as well. So for almost a year, every 2 weeks, I sat in a room with 15 surgeons at 7 a.m. talking about their emotions and communication skills. And it was surprising for them. Someone listened to them. Someone noticed them. And that's the only way that they would later on notice their residents.
Wow, touching, really touching. We have some questions coming in on air as well. So, for instance, I mean, this is not a question. Olga is writing that she was very curious and interested that you mentioned self-reflection as a way to learn better and also to even assess. She's thankful. Um, and then there are a couple
I
of
would
questions.
say to her about reflection is that we actually assess reflection even in our feedback at the end of the course. Do you do an OSCE?
Mm-hmm.
The first thing that we ask the student in the 15 minutes of feedback is let me know how do you feel you did? What went well? What was challenging? And they get 10 points out of the 100 points on reflection.
Wow. But that's really about not being perfect. It's about being aware, like, and being really
And you know why? Because at the end of the day, how many times is a physician really observed?
like zero.
Exactly. Okay. So what they need to actually have as a skill is their reflective practice, their ability to assess what happened in this encounter. Why did the patient react that way? Why did I get angry? What happened to me? How could I do this differently? Okay. So this is critical. This is a critical skill that would impact, by the way, their communication skills, but also their clinical reasoning and
Mhm.
also other things. So that's a different, if you want, that's a different lecture. I can give it to you. That's a lecture already in English.
Wow, sounds good. Okay, next question from Valentina. How do you actually organize teaching, communication teaching? Is it with patients? Is it, yeah, with uh, special simulation equipment? Like, how do you do it?
So, so we do this based in a small group that the students learn. Okay. What we do is at the beginning, we teach it theoretically, and then we teach it. The first time is role plays, when
Mm-hmm.
they actually need to learn their patient role as well as their interviewing role. And later on, with simulated patients.
Mm-hmm.
And later on observing real patients with interactions with physicians, and only later, after they practice a little bit more, interviewing patients. So we actually use quite a lot simulated patients interactions. Not
And
enough, but quite a
And
lot.
do I understand that this path that you just described kind of correlates to like junior, more role plays, and this the more senior they get, the no, it's all
Yes.
in parallel.
No, it's true, but it's in the same year.
Aha, okay.
So
And
if
then,
I
sorry.
so first year of medical school, they have other parts that we teach, but they also have 4 to 5 meetings if for 6 or 8 hours where they do role plays and then simulations and then other simulations and then other simulations. And in between, they go out to the clinic and actually see patients.
Mhm. Yeah. Okay, and then there is another question from Natalia. So at what year do they have these obligatory disciplines or courses that are focused on professional communication?
So it from year one, basically, from year one, every year we have something, but from year one, they do this practice.
Mhm.
Now it includes also physical examination from year one with us, like the practice. And then the day with the domestic violence and stuff like that, we teach it theoretically on year. So you have a 6-year program or 4-year program?
6.
Okay, 6. We have both. So on the 6-year program, the first year is a little bit more detached, but it talks about relationships with patients, with people in general, and observing more community issues. But since second year of the 6th year, they have a very intense one day that is our day that includes theory and includes communication skills and includes simulations and includes observing in the clinics and stuff like that. So the whole year they have one day that is focused on this.
Sorry, 1 day a week?
One day a week that includes um, other issues as well from theory, for example, ethics and law, but one day a week we have now. That includes also the clinical observations and experiences, but
Mhm.
one day a week we have now. And that's for the year two. And year three is a little bit shorter because then they have another course that it takes all their time. And then they go to the clinics. And then, for example, they have a whole day of advanced communication skills. For example, simulations about domestic violence that I said, boundaries, dealing with the patient and his wife who is nagging but has a lot of very important information, stuff like that. And then they have a 30-hour course on breaking bad news that we teach.
And then here comes another, like naturally, another question from Irina. Is this approach and the structure that you just described, is it up to the university to decide what it looks like, or is it somehow obligatory or mandated? Like who decides what this curriculum looks like at a university?
So I would say that until a few years ago, it was up to the university. It's still up to the university. Okay, it's still up to the university. And I admit well, it's recorded. I won't say we do a lot because I don't want them to take off something. But compared to others, we do a lot. So it is up to the university, and it's an investment by the university. It's quite an investment. It is up to the university, but now we're going through an accreditation process. I was the committee of the accreditation process of the international accreditation process by the World Federation of Medical Education. And obviously, they ask about communication skills. And obviously, they want to see what you teach and how you assess it. So if you want to be accredited, you have to have enough. And as you've seen, when I said the ACGME, I showed you that communication relates to really, everyone had only 3 errors. Communication has 6 errors, and I didn't pay it. So it has 6 errors. So if you don't teach it, you will have problems with accreditation.
Wow. So I have a couple more questions from the registration forms. There are some questions about motivation. Do students resist to learning communication, and how do you motivate them or engage them to learn?
So I would say, of course, student resist. That's part of their role.
Who
That's
doesn't, right?
Yeah. Oh, who doesn't? That's a great question. So, of course, they resist, or some of them resist. I would say that even some of them don't resist originally, but then when it's difficult, they resist. Like it could come even later. The best thing that I found to work with resistance is empathy. So when a student resists, says, "Oh, this is wrong," I don't start arguing. I ask questions. So tell me, why isn't it this important? What's concerning for you about this? Why? Let me hear about this a little bit more. And then when I understand their reason for resisting, then I wouldn't even call it resisting at that point, probably. I would call it their concern or their fear or
Mhm.
whatever. Then I give my verbal empathy very, very clearly.
Mhm.
And that just dissolves many of the resistances. I think people really want to be able to communicate well, but there are different challenges. It's scary. They have different experiences with different simulations that went wrong, or something, or someone who judged them, or I don't know, make them angry. So if I relate to this and I see them as a person and I give empathy to this issue, usually they'll go along.
But isn't that also the reason why we want doctors to be able to empathize? Because there is quite a bit of resistance and fear in the praxis, and that is like I think it's a really beautiful quote. Empathy dissolves any resistance.
It does. It
Thank
does.
you.
And sometimes if you do empathy, um, or if you take the identifying of what the reason is, sometimes the reason is really justifiable.
Mhm.
And it may not resolve the difficulty they have, for example, a patient with a treatment, but it may lead the physician to decide on a different treatment with a patient because really that's not suitable for the patient. So empathy is, well, we have the word magic today very much. Often they'll say, well, but yeah.
Wow. Okay, and there is a very specific question. You talked about small groups, and somebody is asking, well, what is the recommended number of students in a small group for better communication skills training?
So I would say it really depends. I would say that the best number is 6. But again, it depends on the hours that you have, if everyone has the opportunity to do it. Sometimes we have groups of 8, and some simulations we do 4 and 4 because they can't handle 8 simulations. It's too much for them. And it's always very funny because I handle the 8. I do the 4 with the first group and then the 4 with the second group. But so it really depends. But it's somewhere between 4 to 8, but somewhere between 6 to 8. I think it allows everyone to be involved. So as an observer, I want them to be involved. So for example, in the first session, I would ask everyone to say something in the feedback. So they'll know that they will be asked. So they have to be attuned to what's happening. Or I would ask someone to write notes about the patient, verbal, nonverbal. Someone to write notes about the students, nonverbal. So I sometimes give them roles, and then they actually expand our ability to learn from the same experience.
And how do they learn how to give feedback? Is that a separate skill that you teach in this course?
Yes. Yes, it's a separate skill. It's a really needed skill.
For sure.
And we teach it. We talk about it. We practice this because they have to give feedback, and we say, wait, I heard you talking about what went wrong. I want you to first think of what works well, and I explain why it has to be that way. Yes, we focus on this.
Wow, thank you. And then there is a question about the interrelationship between communication skills and personality types. Like, can you comment on that? Like, uh, choleric or sanguinic or
Yeah,
any
yeah.
personality traits? Like, how do they correlate? Because with the communication capacity.
Yeah, of course there is a correlation between personality types and specific skills, but I would say that first, so we have physicians with specific types. So our students are with specific types, and that's why every one of them needs to work on another type of skill. So if someone's very human and likes people, he sometimes needs to learn how to set time. That's my problem of stopping things, stopping conversations, ending it up on time. Okay. So the different types of the medical students also plays a role in what I would focus with them when what's their challenge in communication skills. And we need to deal with different patients who have different needs. Some patients need more information, some patients need more empathy, some patients need some patients would identify my concern only if I even if I do it non-verbally. Some need me to verbalize my empathy. So we don't teach the type specifically, but we do bring students different types of patients, because I always tell them everyone has their own challenging patient. One would be challenged by the patient who doesn't talk, and one would be challenged by the patient who never stops talking. So we want to bring them the different types.
But it also sounds like the best approach to managing diversity is again the reflection because it helps you to observe, it helps you to define what you are dealing with, and then it helps you to choose the right response.
Completely agree.
So
I
thank you so much for emphasizing on the reflection as a special practice and a special focus of learning.
Mhm.
Last but not least, I want to ask you a bit about teaching communication in times of war, and maybe you can say a couple of words how this impacts the curriculum, how it impacts your interaction, how you deal with it in a classroom. Um, it's kind of like it's one of those questions that is even difficult to ask, but it's like almost that you know what I'm talking about. So maybe you could share what is meaningful for you at in that perspective.
Um, I, so you obviously know, but being in a time of war, for you and for us, is very emotionally challenging. It feels like it feels like things are not worth, spending, or you can't, or you're uncertain if you'll have the meeting, or you're uncertain if an alarm will, a missile alarm will rise in the middle of your teaching. And I was teaching Breaking Bad News to medical students who were in reserves, and they saw their friends
Mhm.
killed. So we've made a lot of adjustments. Part of the adjustments is talking about trauma and talking about skills to deal with trauma, and allowing them time to share and understanding and support. Other adjustments that for the reserves or for military students, we do special follow-ups and teach them on a different time schedule and in different manners and with a lot more empathy and sensitivity. For example, when in the first year of the war and Breaking Bad News, we took out some of the role plays that we usually have
Mhm.
because we said it's too close, it's too intense, so you have to decide what you're talking about. Um, we acknowledge this in the room. We relate to this. We use a lot of caring, talking about those challenges. I have a wonderful medical student who was in the reserves, and he was in my class. And part of our discussion was the idea that he's wonderful, but emotions, we're detached. And seriously, I was really scared of opening this up because he needs to be detached a little bit because he's in a
Mhm.
war zone. So we started talking together about the ability to touch emotions
Mhm.
when when it's actually something that saves you. Um, and he's done a wonderful process. But I would say that we work with a belief that this is important, but that our students' well-being is even more important. So things would might sometimes be slower. Things would be teary. When I teach, I wear this, which is the hostages sign. So it's on my neck and
Mhm.
it's on my hand. And it's always a reminder of something, that's going on and that I'm not ignoring it. But on the other hand, we teach communication skills because they're so important.
So
And
sorry.
no, go ahead.
So it sounds like one way of kind of addressing the war in the classroom is also about being more personal than usual, right?
Yes. And saying, I understand that you're coming in and not really completely available. We've all seen the news, or we've all experienced the missile attack now, or we're all concerned about our loved ones. And I'll ask students, part of professionalism is that I ask students to say if there's an issue or a problem for them. And I would be more flexible in those cases. I would share that I'm not my best today because my kids are at home and missiles are there and I'm not there. So it's part of saying we live in the same challenging situation, but we're trying to focus and to manage to deal with it. So I told you before that we teach tutors, the clinical clerkship directors, and obviously we spent some of the day focused on how they'll deal with the impact of the war on their students and what's happening to them. So we always start as what's happening to me or what's happening to you.
That's reflection again, basically.
That's my spiel.
Wow. I'm just checking if we got more questions. Yeah, so Lubov is saying that it's really important at this point to teach how to communicate with the patient who came back from the front, or
Frontline, agree.
who was from the front line, or who was released as a hostage. So this is really resonates. Um,
And we learn how to ask about. So before the war, we used to have ASD or ASR. So like acute stress reaction was one of our simulated patient reactions, and people said, "Oh, it's not relevant." What? And then October 7th came, and it was so relevant for so many people. They actually used those skills. And we teach trauma-informed care on about domestic violence and sexual harassment. But then you have to deal with the fact that there was sexual harassment on October 7th or in a war zone. It's really problematic. So we state it, we deal with it, we ask how would you ask about it, but in a manner that is not intrusive, but in a manner that is inclusive and just lets you know how to act and react.
mhm.
These are critical skills not to harm the patient more than they already are.
So, and the trauma-informed care, do I understand it right that it gets integrated into the intense 1 day a week trainings and advanced communication skill training and the course on breaking bad news, or is it a separate module?
So trauma-informed care we have now in three different places. We have on the third year a whole day about domestic violence and sexual harassment, a whole day, 8 hours day, domestic violence and sexual harassment. And then we have a video of trauma-informed care that they can look at and start understanding this. We
Mm-hmm.
a little bit added to how to deal with medical touch in a trauma-informed care manner just before they start the physical examination.
Mm-hmm.
We have it on the whole day that we have it on what you said in the advanced communication skills and the day with domestic violence.
Mm-hmm.
Then they actually need to identify the domestic violence and deal with it. Um, and we added now a module that is not taught by us. It's taught by gynecologists. We made a virtual module where we gave them a lecture about trauma-informed care. We gave them a video showing a gynecologist doing an interview that is trauma-informed. We gave them a video of sexual harassed patient who says what's important for her.
Wow.
Very good video. And then they're actually learning this in the clinical round of gynecology. And now we want to develop one for children and one for pediatrics and one for others. But we just don't have enough time and money. But we'll do
It's
that.
really Halic.
What?
Yeah, this is really an example of it being Halic, like cross-cutting.
Exactly. Exactly. We want things to come back. Otherwise, it's not doing anything.
So it's not just one piece of one course in 1 year. It really has to be repeated in different contexts and somehow consistent across the board with different disciplines. Wow. I think we are just at the starting point of this. Orit, thank you so much for this incredibly rich session. I know that you liked my summary last time with Jane, so I want to do a good job today as well. So let me just try to summarize. I have put like 6 points, well, actually seven, that were really the highlights. The first one is that communication training is not about being nice. It's the skill, especially needed for medical interviews, that is the most performed procedure. So that's number one. Number two, that communication should be taught as a procedure, and that means from day one in small groups with real life observation and exercise. So the third point is that there is a vast body of evidence that about effective communication and how it impacts patients, providers, and organizations. The fourth point is that it's a curriculum and not a course. And I think the spiral learning model is also part of it, and using very different formats and very different approaches to practice it, to reflect, to give feedback, and kind of make it again. So the continuous learning within the program, I think was a key emphasis. And the fifth point, I think was really one of the most striking, how important it is to build relationship with students in a more partner-like way, and also how to add even more respect to those relationships, because that's how you nurture a different quality of relationships for patients. And reflection was the key word of the day, I think. And also, I think it's very neatly related to the what you called a hidden curriculum. I have never thought of it that way, but the curriculum that is on paper, if it's different from the what you show and what you live, then the curriculum on paper doesn't really work. So you really have to, yeah, to live by what you pray. Wow, thank you so much for this session. I'm very grateful that you agreed to do it on such a short notice. I'm so grateful to Daphna, your assistant, also who helped us put all of this together, and to Tanya. And I just want to say that we will do our next session about teaching difficult conversations with Eva Doherty from Ireland, and it will be on the 17th of June. And yes, I hope that we are learning together, and it's a real pleasure to do this. And thank you so much to you and Marcy and each for making these connections possible.
Really my pleasure, and thank you for making this happen. I've learned a lot, and I've enjoyed meeting you and virtually meeting others. And I wish for both our countries and for the countries that are against us that things will settle down. It's time for peace is a huge word. I don't see it happening very soon, but definitely stopping the war. So take care of yourself. And thank you. Mhm.